female genital tract imaging and obstetric imaging. For female genital tract, multiple imaging modalities are used. Ultrasound is considered the principal imaging modality. We perform transabdominal and transvaginal ultrasound. Transabdominal ultrasound will utilize full bladder, but it is difficult in obese patients and if there is surgical scarring and in patients with acute abdomen where we cannot compress the abdomen well, and it has a relatively poorer resolution compared to the transvaginal ultrasound, which is performed with an empty bladder and gives better resolution for the genital organs. Role of CT in evaluation of the female tract is limited to staging of malignancies, especially ovarian carcinoma, and for dissemination of various gynecological malignancies. It cannot demonstrate the normal ovaries and the tubes and has limited resolution and contrast resolution for evaluation of uterine pathology. MRI, on the other hand, has excellent soft tissue contrast, enabling adequate visualization of uterus, tubes, ovaries for various conditions, benign and malignant. Plain radiography has limited role, and the principal investigation that is used using X-ray is hysterosalpingography, and we'll come to hysterosalpingography in a moment. This is a sagittal MRI scan of the pelvis. This is the uterus, and this is the cervix. This is urinary bladder. We start by the role of ultrasound in gynecology. Ultrasound will show the uterus as a pear-shaped organ, seen posterior to the urinary bladder, and it has characteristic midline echo from the opposition of these endometrial walls, and we can measure the endometrial thickness by using ultrasound, and we can detect thickening and detect intraluminal masses. The endometrium, as you see, has echogenic appearance, and the thickness of the endometrium will vary according to the stage of the menstrual cycle, being thickest in the secretory phase. This is the normal transabdominal ultrasound appearance. This is the urinary bladder, and this is the uterus. Transabdominal ultrasound appearance. You can see here that this is the uterine body, cervix, and vaginal canal, and this is axial section showing the uterus and both ovaries, and this is urinary bladder. While notice this is transabdominal again. This is the bladder, and this is the uterus, and this is a transvaginal image. This is the probe in a close-up position to the uterus, showing the better resolution, higher resolution images than transabdominal sonography. Ovaries are visualized on each side of the uterus. They contain multiple small follicles seen as unechoic on ultrasound. The dominant follicle will start to ripe at day 8 till the mid-cycle at about day 14. Sometimes ruptured follicle will be seen as corpus luteum, and free fluid will be seen in the pelvis at the time of ovulation. The normal tubes cannot be evaluated or identified using ultrasound, but dilated tubes or hydrosalpinx can be readily seen by ultrasound. Now we come to the problem of pelvic space-occupying lesions, whether cystic or solid. To start with, we perform ultrasound to determine cystic from solid lesions, and then cross-sectional imaging are required if we have suspicion on ultrasound that we are dealing with a malignant lesion. So the most common lesion affecting the adnexa is an ovarian cyst. Ovarian cyst, this is an example of an ovarian cyst. Ovarian cyst can be either simple or complicated or complex. A simple cyst refers to only fluid content with thin wall and with no solid nodules. Fluid will appear unechoic on ultrasound with no solid. So simple cyst is thin-walled, unilocular, unechoic with no solid portions. Persistence of follicle in non-pregnant patients or corpus luteum in the first trimester may result in functional cyst. On CT, the cyst will appear to have a fluid density from 0 to 10 ounce per unit, and simple cyst will show very thin wall that is non-enhancing. On MRI, the cyst will have high signal on T2 and low signal on T1, and if it is simple, it will show no internal septum and no nodules and no areas of enhancement if we give contrast. And this is an example of a simple ovarian cyst. You see no definite wall, or very thin wall, and no solid content. What about polycystic ovaries? Polycystic ovaries are different from ovarian cyst. Polycystic ovaries are large volume ovaries with multiple small follicles. So this is an example of polycystic ovaries. So make a distinction between ovarian cyst and polycystic. Polycystic is a functional condition. You have enlargement of the ovaries and you have multiple small cysts typically distributed peripherally around the central stroma. One of the cystic or complex cystic lesions that can happen in the ovary is dermoid cyst. Dermoid cyst or teratoma commonly involve the ovary. Sometimes detected on a plain X-ray, seen as calcification or as low density mass in the adnexa, okay, variable amount of calcification. On ultrasound, it has variable appearance, typically a complex. By complex, I mean that the cystic lesion will have areas of solid content, then will have areas of fluid content, we have areas of wall thickening. So it has apparently like cystic and solid composition. On ultrasound, various appearances can be seen, such as layering of fluid in this example of dermoid cyst, and various other ultrasound images. It can be completely echogenic. It can have part that is anechoic and some portion that is solid. It can have areas of, can have this fatty fluid level, can have this short lines suggestive of the presence of hair, calcification. All these are variable ultrasound appearances of dermoid cyst. So how to confirm if it is so variable on ultrasound, how to confirm the diagnosis? We can perform either CT or MRI. CT will show an adnexal mass with variable amount of calcification but with the presence of fat. Fat is seen as negative value on CT, typically less than -30. So this is a lesion with variable amount of fat, can be entirely fat or can have areas of patches of fat, as you can see in the classification. And on MRI, it will appear hyper-intense on T1 and T2. This is T1 weighted image. Content is hyper-intense. Hyper-intensity on T1 is either blood or fat. If we perform special fat suppression sequences, so if this hyperintensity goes or fades or becomes black on fat suppression sequences, we know that this is fatty dermoid cyst. Now we come to the other complex ovarian lesions. Cystadenomas and cystadenocarcinomas are the commonest lesions presenting as complex cystic masses. For cystadenomas, they usually have thin cyst wall and thin septation and no significant solid components, while malignant lesions, on the other hand, will have mixed solid and cystic areas. They will have thick wall, nodular septations, and we can appreciate vascularity within the lesion on color Doppler. Sometimes we will notice also the presence of ascites or peritoneal deposits, diagnostic of malignant process. Invasion of the surrounding organs can be seen in advanced stages, such as the bladder, rectum, and the bowel. Presence of lymphadenopathy, presence of liver metastasis, all can be evaluated on imaging. So you see here, this is example of a cystic ovarian lesion, and you see here these solid regions, solid areas, neural nodules. Immediately, this is not the appearance of a simple cyst, this is not the appearance of a functional cyst. This is a neoplastic cyst because you have multiple solid lesions, and you have this multilocular cystic lesions. You have thick wall, you have multiple internal septa. So multiloculated cystic tumor with thick septa is suspicious for neoplastic lesion, and solid nodules is suspicious for neoplastic lesion. The higher the number and the size of the solid lesions, and the higher the thickness and the number of septations and the complexity of the lesion, goes more with malignant cystic lesion. MRI will will help us to characterize the mass as benign or malignant, and PET-CT can be used to demonstrate the extent of disseminated disease to aid in treatment planning. This is an example of a complex ovarian cyst seen on ultrasound. This is the cyst. This is the cyst seen on ultrasound. You notice you have wall, you have a solid nodule within the cyst, and you have a septum. And on MRI, you can see that this cyst, this is urinary bladder compressed by the cyst, have a large solid content, and the presence of large solid content is suspicious for malignancy. Staging can be performed in. Characterization is performed by MRI. As you see, we characterize the lesion on MRI. We stage by CT, okay, abdominal and chest CT. We stage by CT to look at lymph nodes and distant metastases. PET CT is also a useful investigation method. This is PET scan showing multifocal dissemination within the chest, within the abdomen, within the peritoneal cavity in this patient with disseminated ovarian carcinomatosis. So the role of imaging in ovarian carcinoma. The optimal treatment of ovarian carcinoma is by surgery, hysterosalpingography, and bilateral salpingo-oophorectomy and hysterectomy for surgical removal of all macroscopic tumor. Formal staging is usually carried out during surgery. Preoperative imaging may be used to provide the surgeon with information concerning the extent and distribution of macroscopic disease. Imaging also plays an important role in post-operative follow-up. Okay, so preoperative imaging will guide the surgeon. It does not the best staging is done at surgery and by pathologic evaluation. However, we have what is called the clinical staging. By preoperative imaging, we will help the surgeon information about what he's expecting to see as surgery, and also in post-operative follow-up for follow-up of the lesion and to assess for residual or recurrent disease. Now we come to the problem of uterine masses. The most common uterine masses seen in the clinical practice is fibroids, seen as single or multiple, intramural, subserous, or submucous. Subserous means that they are peripheral. Okay? They could be pedunculated subserous lesions. Submucous means that they are protruding into the endometrial cavity, and intramural means that they are within the muscle of the uterus. Plain film is usually not helpful. It may show calcification in fibroid. Ultrasound will show us the fibroid clearly as lobulated or rounded masses of variable echogenicity with or without calcification. CT is not so good. It will show just soft tissue mass. MRI will give a very good characterization and will show the signal intensity of fibroid and the presence of degeneration. This is the typical appearance of fibroid seen within the muscle of the uterus. This is a location. We classify this as intramural subserosal, meaning that it is both within the muscle and having a component that is bulging the serosa of the uterus. And you have this appearance sometimes, if it is calcified grossly, can be seen on X-rays. You can see here, this is what's called popcorn calcification of fibroid, and this is uterine fibroid seen on MRI as a mass that is hypointense relative to the uterus, but it can have variable high intensity. Most commonly, it is seen as hypointense on T2. Another condition that is affecting the uterus is called adenomyosis. In adenomyosis, which is invasion or proliferation of endometrial glands within the myometrium. In this condition, the uterus is typically enlarged. On ultrasound, there is heterogeneous increased echogenicity in the myometrium. On MRI, we will see focal or diffuse thickening of the junctional zone, and multiple bright projections are seen extending from the endometrium into the myometrium. This is the normal myometrium on MRI. This is the junctional zone, which is a hypointense layer on T2, seen immediately adjacent to the endometrial canal. This is the normal appearance. While in adenomyosis, there is a gross thickening and heterogeneity of this zone, of the junctional zone. If we measure it, this is very, very thick and with increased heterogeneity. This condition predisposed to heavy menstrual bleeding. What about cervical pathology? The most important pathology is carcinoma. The diagnosis of cervical cancer is generally clinical by direct visualization of the cervix. Cross-sectional study, mainly MRI, will help staging of the extent of the tumor within and outside the cervical canal into the vagina, uterine body, parametrium, rectum, bladder, pelvic sidewalls, and for assessment of pelvic lymphadenopathy and for assessment of obstruction of the ureters. This is an example of CA cervix showing a heterogeneous high signal intensity mass lesion. It is T2 weighted image, normally the cervix. This is the normal cervix. Normally it is T2 hypointense. And in cervical carcinoma, there will be altered signal intensity. This is a gross mass seen extending anteriorly, reaching to the bladder, possibly invading the bladder, and extending inferiorly, invading the vagina. Posteriorly, it is not invading the rectum, so we can characterize the lesion on MRI to see for the extent and involvement of the adjacent organs. Contrast, heterogeneous enhancement will be seen, and enhancement of the invaded areas will be clearly seen. Contrast will help further evaluate the extent of the tumor. And for endometrial carcinoma, the use of imaging to stage the tumor at the presentation is limited, but MRI can predict the depth of myometrial invasion. Both CT and MRI can demonstrate distant disease and lymph node involvement. Patients with endometrial carcinoma commonly will present with postmenopausal bleeding. Investigation to start with in patients with postmenopausal bleeding will be uterine ultrasound. If ultrasound shows me thick endometrial cavity, thickening of the endometrial cavity, this could represent endometrial carcinoma or endometrial hyperplasia. The next step in the workup is to perform endometrial biopsy. If endometrial biopsy showed endometrial carcinoma, then the next workup will be by MRI. MRI of the pelvis in patients proved by endometrial biopsy to have endometrial carcinoma will help me to see the extent of tumor, mainly the depth of myometrial invasion. But we can see also extensive disease involving the serosa, involving the ovaries, involving the pelvic side wall. It is generally for local staging of approved endometrial carcinoma by endometrial biopsy. Okay. Now we come for another pathology, which is pelvic inflammatory disease. Pelvic inflammatory disease, the most common cause is infection, gonorrheal infection leading to tube ovarian abscess. However, there are other causes of sepsis in the pelvis, such as complication of pelvic surgery, childbearing, appendicitis, and diverticulitis with spread to the tubes, abortion, and the presence of IOCD. To start with, we start by ultrasound. Ultrasound will show hydrosalpinx or pyosalpinx, which is a dilated tube, dilated tortuous ovarian tube. It can show me abscess, seen as cystic or complex mass lesion with septation. Sometimes it is indistinguishable from tumor by ultrasound, however, because it also presents as a complex mass, but the clinical picture and the lab workup will differentiate between the two, and we may see free pelvic fluid. The differential diagnosis of hydrosalpinx and of a complex endoadnexal lesion will also include endometriosis and ectopic pregnancy. So this is CT scan of the pelvis showing this large, like a mass lesion. Bilateral adnexal lesions, you can see here that this is cystic lesion with multiple internal cystic content, thick wall, thick septation, enhancement. So this is could be a tumor, but in the clinical context of infection and discharge and raised inflammatory markers, this is a case of tube ovarian abscess. Endometriosis. Endometriosis is seen on ultrasound if it forms endometrioma, or what is called chocolate cyst, which is a cystic collection of endometrial tissue that bleeds with the menstrual cycle of the patient, forming endometrioma, typically in the adnexal region on the ovaries. Ultrasound will show cystic or complex mass lesion with or without pre-pelvic fluid, especially at the time of menstruation. The endometrioma will typically show this cystic lesion with low-level echo. We call this low-level echo because it is not completely hypoechoic. It is not completely anechoic, but it has this very low floating echogenic content, such as the roof endometrioma. On MRI, we will see a lesion that is hyperintense on T1. Okay, we said that hyperintensity on T1 could be related to the presence of fat or blood. When we perform fat suppression sequences, when we suppress the fat, the hyperintensity will persist. So we know that this is blood, and the blood in an adnexal lesion means that we are dealing with endometrioma. Now we come to the investigation hysterosalpingography. We said that the role of X-ray in assessment of the pelvic organs is limited to hysterosalpingography. In hysterosalpingography, we use iodinated contrast injection into the uterus through the cervical cannula. It will show me the endometrial cavity, fallopian tubes, and follow the free spillage of contrast into the peritoneal cavity. The indications of hysterosalpingography is mainly infertility to assess for tubal patency. This is the main investigation that I want you to know about. Also, it is used in the assessment of congenital anomalies of the uterus. This is an example of hysterosalpingography. You see opacification of the uterus. This is arcuate uterus with depression and the fundus. This is the cannula, the balloon, and the contrast is injected into the uterus, and this is the tube, and this is the free spillage into the peritoneal cavity. And this is a unicornuate uterus, congenital anomaly of the uterus. When we have only one horn, this is a unicornuate uterus, showing, of course, these patients present commonly for infertility because of the underlying anomalies, but it can be seen. We can see also normal uterus, but with blocked tubes as a cause of infertility. We have another investigation, is called sonohysterosalpingography. This is cannula introduced into the cervix, and we push fluid and visualize by ultrasound. So if we have suspicion of uterine polyp, or we want to delineate the endometrium to differentiate between polyp and thickening, we use this investigation, and it will show us the separation of the endometrial cavity, and we can evaluate for the presence of pedunculated lesions within the endometrial cavity. This is what is called sonohysterosalpingography. Okay, by this we complete the talk about gynecological imaging, and we proceed with the obstetric imaging. For radiological studies in obstetrics, ultrasound is the modality of choice in the diagnosis. There is no evidence of biological hazard on the growing embryo from ultrasound. We generally perform two types of ultrasound, either transabdominal ultrasound or transvaginal ultrasound. Transvaginal ultrasound TVS allows early diagnosis of pregnancy and early confirmation of fetal cardiac pulsation 1 week earlier than transabdominal ultrasound and with better resolution. From 5 weeks onward, we calculate 5 weeks from the last menstrual period. The gestational sac appears as rounded cystic structure inside the uterus. We used to measure the mid-sac diameter for assessment of the gestational age before appearance of any fetal structures within the sac. On 6 weeks, a fetal pole is seen as linear echogenic structure in 6 weeks. By 7 weeks, now we are able to measure the crown rump length, which is the distance from the tip of the head to the tip of the torso. Crown rump length, used for gestational age assessment until the week 12 gestation. And in 7 weeks also, we can observe fetal heart pulsation. In the first trimester, we perform what is called nuchal translucency. which is measurement of thickness of the fluid at the back of the neck, done at 11 to 14 weeks. This is useful in detection of some chromosomal syndromes, mainly Down. This is the normal nuchal translucency, and this is the increased nuchal translucency in this child with chromosomal anomaly. Also can be seen in some structural malformations. So ultrasound in the first trimester is used to confirm the presence of a pregnancy and is used in establishing the chorionicity and the amnionicity of twin pregnancies. We will decide whether it is singleton or the pregnancy is a twin gestation, and in twin we will differentiate the diamniotic, dichorionic from monoamniotic from monochorionic pregnancies, and we will confirm the fetal viability. So gestational age detection, viability, dating, and assessment of number of gestational sacs. What about the second and third trimester? In second and third trimester, we use transabdominal ultrasound to assess the fetal, to follow fetal maturity. So we measure the biparietal diameter and the femoral length. By comparing the measurement with the standard growth chart, we can estimate the gestational age. Dating is most accurate between 18 and 20, and it is also suitable to identify fetal anomalies. So in the second trimester, we measure the biparietal diameter. This is the biparietal diameter, the measurement of the fetal head, the largest diameter of the fetal head, and we measure the femoral length, and by estimating, we can estimate the fetal age. We can follow the fetus for growth, for proper growth, and we can diagnose large 4-date fetuses and fetuses with IUGR. And we can assess also for detailed anomaly scan to assess for congenital anomalies. The placenta is also visualized. It is generally identified from the 9th week onward, and we follow it for the location of the placenta and for diagnosis of placenta previa, generally after 20 weeks of pregnancy. So we said that for the second and third trimester, it is used for dating of a pregnancy, and it is used for also the assessment of the fetal growth and assessment of fetal viability. Now, if we are following the growth of the fetus, sometimes we will encounter a larger 4-date uterus. Larger 4-date uterus can be due to incorrect date, can be due to multiple pregnancies, molar pregnancy, polyhydramnios. These are clinical causes, and association of pregnancy with uterine or ovarian masses. All these can give rise to large 4-date uterus, and obviously ultrasound will help us to see the cause for large 4-date uterus. Polyhydramnios is associated with maternal abnormalities such as diabetes, and with a number of fetal conditions such as neural tube defects and obstruction of the alimentary tract of the fetus, such as esophageal or duodenal atresias. And polyhydramnios can also occur normally in multiple pregnancies. We evaluate polyhydramnios by measurement of the amniotic fluid index, and if we see across the increased amount of amniotic fluid, we measure it, and we can diagnose polyhydramnios easily by ultrasound. We can assess the fetus for the congenital anomalies that is producing that may contribute to polyhydramnios, such as assessment of a neural tube defect such as spina bifida, and assessment of GIT abnormalities such as esophageal or duodenal atresia. We can evaluate the fetal stomach, and we can evaluate the fetal body for various anomalies that can produce this condition. And what about small 4-date uterus? Small 4-date uterus can be due to wrong date or can be due to IUGR, intrauterine growth restriction. We have two main types of IUGR. We have the symmetric IUGR, which starts early in pregnancy. Both the biparietal and the abdominal circumference are affected symmetrically. This is usually associated with congenital anomalies and intrauterine infections. While the asymmetric IUGR is generally diagnosed at the third trimester, it means that it affects the body more than the head and is usually due to placental insufficiency. So if we measure the biparietal diameter and it gives us about 36 gestation, and we measure the abdominal circumference and it gives us about 32 gestation, so we know that we are dealing with asymmetric IUGR. Fetal death, it is possible to see the heart beating and observe fetal movement on ultrasound from the 7th week of pregnancy onwards. Failure to observe these phenomena suggests fetal death. But in the early stages of pregnancy, one must be careful that the gestational age has not been calculated correctly. So it is therefore important to repeat the scan after a suitable interval if there is any doubt. So as we said, that fetal death is failure to visualize the fetal heart pulsation. But we have to be cautious in diagnosis of fetal death before the 9th week of gestation and first pregnancy. So if we saw a fetus with a gestation of about 8 weeks and we don't see fetal activity, we can postpone the exam, give it about 1 week to prove that we are not seeing any progress and the heartbeat will not appear. So we may choose to repeat the scan. Now for the last topic about ectopic pregnancy. Ectopic pregnancy is the presence of pregnancy outside the uterine cavity. The most common type of ectopic pregnancy is adnexal ectopic. Positive pregnancy tests in the presence of intrauterine gestational sac highly suggests ectopic pregnancy. So if we have a female, a lady with a positive pregnancy test, and we perform ultrasound and we saw no evidence of intrauterine pregnancy, so this is suspicious for ectopic pregnancy. The presence of adnexal mass lesion with fetal pole inside the mass is 100% diagnostic of the condition. So empty uterus plus an adnexal mass with fetal pole inside. But this is very rare to be seen. Most commonly we will see empty uterus, only thick endometrial from visualization, and we will see a complex adnexal mass that looks like a cystic lesion that has a thick wall but no definite fetal pole, complex adnexal mass interposed between the ovary and the uterus. This is the most common appearance of ectopic pregnancy. Free fluid, large amount of the free fluid will be seen if the cyst ruptures. Ectopic pregnancy generally presents with sudden pain due to rupture of ectopically placed gestational sac. The ruptured ectopic pregnancy itself is not always visible, but in ultrasound an adnexal mass having both solid and cystic characteristics, and occasionally a fetus can be seen within, and there should be no intrauterine pregnancy. So this is an example of an ectopic pregnancy with a cystic lesion having thick wall and having, if we put color Doppler on, we will see peripheral vascularity of this lesion on Doppler. This is suggestive of an ectopic pregnancy. Free fluid may be seen in the pouch of Douglas from hemorrhage. However, pelvic inflammatory disease and rupture of adnexal cysts and various neoplasms can give identical appearance. So in clinical practice, if the pregnancy test is positive and no intrauterine gestation can be identified, the obstetrician may assume that there is an ectopic pregnancy. He will send the patient for ultrasound, and in the presence of a complex adnexal mass lesion on ultrasound, so the diagnosis is become very apparent that the case is most likely an ectopic pregnancy. Any questions? فهذا كان المادة المطلوبة من عندكم. وصلنا إلى نهاية المحاضرة إن شاء الله، وإذا ما عندكم سؤال تقدرون تاخذون راحتكم.
شكرا دكتورة.
أهلا